You've seen our research on social media. Now, join us as we dive deeper into the public health topics of our time, featuring new studies and findings generated by our faculty and researchers committed to advancing health equity. From the Department of Population and Public Health Sciences at Keck School of Medicine of USC, this is Preventive Pros, the podcast.
I'm Jennifer Tsui. I'm an associate professor here in our Department of Population and Public Health Sciences. I'm also the director of Cancer Care Delivery Research and Implementation Science at our USC Norris Comprehensive Cancer Center. I'm a health services researcher by training, and I think most of my research currently focuses around implementation science and mixed methods approaches to understand access to and quality of cancer prevention and control and evidence-based strategies around cancer control. The HPV vaccine is something that I've been researching in my career since I first got into public health. So I sort of started in public health because I was interested in diverse communities, racial and ethnic communities, specifically here growing up in Los Angeles. And then as I was moving through my own MPH program, which was in New York in epidemiology, it was right around when the HPV vaccine was first about to be introduced. And I realized that this was such a amazing tool, right? We were going to be introduced to this new vaccine that at that time was really focused on the ability to prevent cervical cancer or the high-risk HPV types that are most commonly associated with HPV cancer. And over the years, the messaging around the vaccine has changed. It's not only for cervical cancer in women, but it's for protecting multiple other cancer sites that are also strongly associated with HPV infection. I think back in 2006, when the HPV vaccine guidelines were first being introduced, I was an intern at the Centers for Disease Control. And I was there because I was mainly interested in breast cancer and cervical cancer screening and breast and cervical cancer prevention. And my work there at the CDC that summer as an intern really shifted to understanding, what is this vaccine? What are the guidelines that are going to come out? And then all the sort of science up to that point around engaging communities that experience disparities, and what we would need to do to make sure that this new tool would be accessible and would be taken up by all the communities that are disproportionately burdened by cervical cancer was what sort of drew me in. Right. I was a cancer prevention and control sort of researcher or public health practitioner at that point, and then realized, this vaccine's coming out and it's this new opportunity to further prevent cancer. So I was really interested in that. I never thought I would still be focused on HPV vaccination almost 2 decades later. But what we've learned about the landscape of HPV vaccination is that it's complex, right? The guidelines first came out just for women or girls and young women. And then the guidelines shifted to also include boys. The messaging in the beginning centered not just around cancer prevention, but also because HPV is a sexually transmitted infection. There was that component. So a lot of complexity around that, around communication. And then also it was a vaccine that was not going to be mandated at that point for school entry like other pediatric or adolescent vaccinations. So that became an aspect of health policy that really got me interested and got me intrigued into things beyond just community engagement and community-based interventions. I think the complexity around HPV vaccination, the delivery of it, the settings where it was needed most, was probably what pushed me from being an MPH student and then a CDC intern and then into a PhD student that was focused on health policy and management. So really sort of, I think it was my experiences early on with doing, work around this vaccine that have guided what my questions and interests are overall in public health and in cancer control research. So I think, I mentioned in the beginning that I'm a health services researcher by training, and I work in the implementation science field, and a lot of my approaches are mixed methods. So I collect qualitative data and quantitative data to address the research questions I'm interested in. But I would say first and foremost, I'm a health equity researcher at heart, right? Almost all of my research activities and the questions I want to ask are around that, right? Why are some groups experiencing a disproportionately higher burden of certain cancers when there are specific tools available to prevent those cancers or to detect those cancers early, or to treat those cancers in a way that would give patients the best optimal outcome possible. So with HPV vaccination, I realized, I really am interested in moving in the sort of healthcare delivery and the policy arena. So I currently lead a multi-year National Cancer Institute funded study to understand how safety net settings, so clinics serving medically vulnerable or medically underserved populations, how those settings implement and adopt strategies to improve HPV vaccination among adolescents in their clinic settings. I also have other research understanding barriers to vaccine uptake, including increasing vaccine hesitancy around minoritized groups and minoritized communities. I'm very interested in sort of communities where linguistic access to vaccine information might not be available. And so many of my recent studies are around how do we move evidence-based strategies, evidence-based interventions that we know could improve HPV vaccination. Is sort of the evidence we've learned over the last 15 to almost 20 years now. How do we move those into the communities that really are the ones that are experiencing the disparities in cervical cancer and in other HPV-associated cancers? So a lot of my research partnerships and a lot of the settings I engage with are federally qualified health clinics, federally qualified health centers. Many of them are mission driven and community aligned, so they have target communities that they work with. Many of their providers are culturally concordant or from the communities that the clinic serves. And I think these clinics are also lower resource settings in many ways, right? So while we have evidence that, provider trainings or EHR alerts might work in these large, robust health systems, how do we get that evidence and how do we adapt that into F2HCs so that these effective tools can be used to promote HPV vaccination? That's what I'm interested in, right? It's the process of how implementation adoption happens. Some of what we've done in our current NCI study is really engage the system level, the providers, as well as the clinic staff to help us adapt our training content and our communication materials so that they are aligned with what the providers and clinic staff have told us, but also what they tell us the patient barriers are. So with HPV vaccination, from not just this study, but many other studies prior to this, we've learned that there's still this notion that the vaccine is sort of new or they've never heard of this vaccine. In part, it's because it's not school mandated. In part, it's because many providers some providers have offered it as an optional vaccine because it's not school mandated. So the sort of messaging gets a little bit confused there. But I think it is also more recently around the impact of the COVID-19 pandemic and the COVID-19 vaccines, right? There is so much access to so much information out there that being able to discern sort of what's trusted in terms of scientific information or healthcare information, I think is a big issue now, right? So being able to address HPV vaccine safety, HPV vaccine long-term effects, right, are pieces that we need to make sure we not only equip the physicians with, the pediatricians with, but also the clinic staff, right, to make sure that they have the terminology and the tools and the talking points in case a parent or a patient asks them about, well, does it cause fertility issues? Or I've heard it's unsafe, and once you get the vaccine, it'll cause you to, be more susceptible to other certain risks, right? These are all hesitancy factors that maybe existed before the pandemic, but because of increasing vaccine hesitancy overall, they've just been heightened for HPV vaccines more recently. So it's really thinking about the community, right? For the long-term impact on fertility is something that both physicians and clinic staff have told us in our current study is something parents bring up. The need for differing messengers and information sources. We, a few years ago, worked with our USC Neighborhood Academic Initiative, which is a program that we're co-located with in our department, in our building. And we had surveyed the parents in their program to understand their thoughts around HPV vaccination. And what we realized was messengers, right? Who the key messengers are in the community and who the trusted sources of vaccine information is really important too. So it's not just the message itself that we need to adapt and focus on to be community relevant. It's also who's delivering the message and the multiple channels where vaccine messaging could be disseminated so that we sort of address vaccine hesitancy from multiple directions and in multiple ways that are effective. So much around vaccine hesitancy, but maybe just the complexity and the multi-levelness around barriers to vaccination, right? So the HPV vaccine, if you start the series before age 15, you only need 2 doses, but afterwards in the catch-up vaccination group, you will need 3 doses. I think you can have a really strong health system and lots of system level, provider, clinic team level strategies to make sure you address all the missed opportunities for vaccination. But at the core, you still need to make sure, or we still need to make sure that communities have access to health services and preventive care in general, right? So it's making sure people are coming in for their adolescent well checks. It's making sure that, starting from that as young as age 9, that the vaccine is being offered at clinic visits. I think there is still not just the within clinic setting strategies that we need to focus on. There's always that bi-directional engagement with the community that I think is so critical, which is why I would say the part I like about trying to tackle HPV vaccination as an issue is that it's almost always team-based, right? It's almost always multidisciplinary. And I love that we have to sort of think about how to address this problem from so many different perspectives. The second piece that I think is important is that the pandemic also caused a lot of families to delay their well child visits. And so even though we're concerned about catch-up vaccination groups, so the older adolescents and the young women who maybe for some reason or another didn't get their HPV vaccination in that target 9 to 12-year-old group, that's always been a concern, catch-up vaccination groups. But I think more so after the pandemic, because we've known that there's this whole maybe cohort of adolescents who miss their well visits, during the pandemic, that catch-up is even more important, right? There was a NCI or HPV Cancer Center Consortium webinar that I co-hosted last week about this issue, sort of all the aspects of HPV vaccine catch-up that we might want to focus on. For the first time, I think in several years, HPV vaccination uptake has not gone up. And those who are uninsured, or I think Medicaid insured, actually have lower rates. It used to be the opposite. It used to be safety net setting populations, at least at the national level, had slightly higher rates, but we're seeing that that's not the case now. So really targeting sort of the root of access to care and continuity of care and preventive care still now, I think, is more important in both the target HPV vaccination group and in the catch-up vaccination age ranges. So I think what I've learned along the way is there's no magic bullet, right? There's not like a one-size-fits-all intervention. And while it's really important to build upon the evidence base, I think my specific area of focus in implementation science for HPV vaccination, at least, is to understand how we need to adapt or how we need to update or align with the specific communities and clinic settings and contexts that need these strategies the most. And that requires really sort of understanding factors around community-specific hesitancy barriers, community-specific access barriers, but also working with sort of the clinic and the systems themselves, right? What's the culture of that clinic system? Is it sort of top-down change? Is it bottom-up change? Who are the champions within these healthcare systems and these community clinic settings that can really be a partner and a sounding voice and what would work best for their setting? It's really engaged implementation science, right? And so I think that we have a lot of really great evidence from community trials or cluster randomized trials on what sort of strategies may work and what multiple components are needed to improve HPV vaccination. And I think now in our work, it's really to understand, okay, how do we now take that learning and that evidence and get it implemented in these settings that are slightly varied? How do we get it to work again, right? Who do we need to hear from? How do we make it still high fidelity in terms of the intervention, but strongly adaptive and fit for the context of the populations that we know still need a lot of this work to be done in? With the HPV vaccination and with the screening tools that we have for cervical cancer, I think it's one cancer that we can eliminate, right, in our lifetime. And I think as a health equity researcher, that's probably the underlying motivation for why I keep going after this, right? It's that it is possible with the vaccine and with our cervical cancer screening tools that we can start to eliminate people getting cervical cancer, at least over the next few generations. So that to me is exciting about cancer control.
Preventive Pros, the podcast, is produced by the Department of Population and Public Health Sciences at Keck School of Medicine of USC. To learn more about any of our episodes, or to subscribe to our monthly Preventive Dose newsletter featuring the latest in public health research and news, visit pphs.usc.edu/podcast. Thank you for listening.